It wasn't, there was no statistically significant heterogeneity. The treatment effect was slightly bigger in high-income countries than low and middle-income countries, but it was still in the same direction, and there was no significant heterogeneity. I think the relative risk was something like, for high-income countries, it was like 0.78, and for lower middle-income countries, it was 0.82 or something like that. 1.0. Is that right? You've got a very good memory, but let's have a look. So this is the treatment effect in high-income countries, 0.72, and this is the treatment effect in lower middle-income countries, 0.83. Obviously, they're both statistically significant. Well, I used that term. I said yesterday we should never use that term. Never mind. Strike that off the record. It's slightly more imprecise in the high-income country because there's fewer events. That's why we go to lower middle-income countries, because there's lots of events. But these two results, this is lower middle income, this is high income, they're not different from each other.
I think you had another slide.
You mean about the severe head injury?
Oh yeah, I did.
Because there was a difference.
There was actually this one. Yeah, in fact, these two are not statistically significantly heterogeneous either. But this was a sort of, I think we have to, even though there was no clear evidence of heterogeneity, you can still think, well, maybe there is heterogeneity. Yeah.
But we have to think about the background of logistics about ambulance. When you mean high-income country, if something happens, we just call and the ambulance come.
Yeah.
They come, but in low-income countries.
The other thing about low-income.
Anyway, this trial itself is just comparison of the mortality rate and also the treatment only.
Yeah, the thing about this is that you can, even, let me go to that last one at the end. This one. The death rates are different, right? So, take extracranial bleeding. 10% of patients die, 20% of patients die. So the death rate can differ largely, but the effect of the treatment effect is remarkably homogeneous. And I think that's because it's about the treatment's working at the level of biology, and actually the difference between a poor person bleeding in Africa, as far as the drug is concerned, is the same as a wealthy person bleeding in England, because it's about the interaction of the drug and the target, and actually how wealthy the patient is or where they are doesn't really come into it. So the treatment effect is remarkably homogeneous, even though
Actually, if we think about the ambulance department in high-income country, low-income country, maybe ambulance doctors, some doctors will be good at using catecholamine or something, or some other cardiovascular drugs.
Maybe. The other thing about low and middle income countries is that
I'm not sure in the lower income countries how they use this kind of drugs. But it depends. I mean, in a higher income country, although they have a lot of cardiovascular modulating drug, it doesn't necessarily guarantee that they are good at to handle this kind of drug.
Yes. I find that when people think about low and middle income countries, they think they're homogeneously low and middle income, but they're not. there are actually, it's much more varied than that. That you can have a country that's poor on average, but there are some really excellent places all over the place. And actually, the doctors in low and middle income countries, I generally find, are better at evidence-based medicine than they are in high income countries because they need to be. Right? They can only afford safe and effective treatments, and so they've got a real need to identify what's worth paying for and what's not. In UK hospitals, if you go into the emergency department, they're crowded with machines, and they don't do anything. You know, there's technology everywhere that industries have forced in there. I'm sure it'll be the same in Japan, but these machines, you know, there's no evidence. In most cases, there's no evidence that they improve outcome. So they look very modern, but when I go to a hospital in Peru or something like that, you know, there's not much there. There's not much there, but what is there is what they need. That's what I find.
So, what is the motivation to get collaboration with international relationship? So, what is motivated?
What motivates me to get internet? Well, first there's the idea of doing something that's big. I think everybody goes through this realization that you can do lots of things, you can do lots of small things, but they don't really make any difference. And that actually, if you could put all of your effort into a fewer things that really did make a difference, it would just be a better use of your time. So that's one thing. And then the other thing is that I just quite like people. And it's just nice. You know, it's just really good fun. The big trials are actually much more of a social challenge. I'm not as good as it. There are people, that's the other thing I'm not as good at it as some of the other people. So I work with people who are much better at it than me. Even though I do like people, I'm still a little bit introverted, like lots of academics. You know, I can get really sort of caught up with an idea. And, you know, I can sort of not notice people and, you know, I mean, you see them in universities all the time, walking around the corridors. You know, good morning, Professor. You know, I can be a bit like that, you know, a bit sort of in my head. Whereas the people I work with are much better at working with people.
Because so it is very hard and difficult and tough to get collaboration with people in other countries. So
No, that's not true. It's absolutely not true. I find it's completely the opposite. This is how I see it, right? There's a big world out there, right? And then and lots of doctors who feel excluded from the world of research, right? They see thousands and thousands and thousands of patients, but they can't contribute to research to improve outcome for those patients one bit, right? They're completely excluded from the world of research. And you say, actually, here we are, come on, you're welcome. And actually, not only are you going to participate in the world of research, but you're going to do research that's world class as well. Honestly, you can't stop them. You can't stop them. There are more people who want to work with you than you could ever imagine. And as soon as you realize that, you know, you say, well, just open door. That's a food.
My question is similar. So I think it's very awesome. You could know so many people from so many countries. I think it's a key, very key of your success during these huge trials. So I want to know what's the most important issue to move people. Actually, I I'm managing a much center for such study, and I'm very struggling to remove people. So I want to know what you about it.
So you're struggling to recruit patients. So, like, first you have to simplify things, I think, right? So you can't do big things that are complicated. So you have to really simplify things. You have to make difficult choices. Because when you start off doing research, you say, I want to collect all of these papers. Oh, that would be interesting if we collected data on that. And oh, that, yeah, what about that? And every, data collection instrument gets very long. That's not going to work. If you really simplify things, and it's about this marketing thing that I was telling you. You've got to simplify things. You've got to have, you've got to, all of it. You've got to have what are the values, brand values of doing this. You've got to take yourself out of it. People with these trials, we're not asking them. I'm not asking them to help me. I'm asking us to do something together. I mean, they do help me, of course, and the university is happy that we do these big trials, but we say that the idea is we're trying to do something together, and it helps them as well. So, I mean, the first trial. The first big trial we did, the Crash 1 trial, we like to name the trials by the collaborative group, but sometimes when it's indexed in PubMed, PubMed likes to put names to it. So my name is, I don't know, something like around the 300th name, and in fact because we listed the names on the paper alphabetically. And so Miguel Arango is the first author. He was lucky to have A as a surname. So the first author is Miguel Arango, and the second author is somebody Arturo or something like that. And because I'm Roberts, I'm down at, But, I don't know. There's too much. There's too much you have to say to answer your question, really.
So my question is: when you started your first trial, Crash 1, so how did you find your mentor to conduct large international trial? Because you told us that no textbook told us how to conduct large trial. So in reality.
Yeah. So what I told you that we were we copied the cardiologists. And so there's a guy called Richard Peto and Rory Collins. There are two people, Richard Peto, Rory Collins. They work at the University of Oxford. So I said, right, we want to do a randomized trial, a big randomized trial in head injury, like you've done in cardiovascular disease. And we asked if they could help, and they did. They had learned from trial and error over a period of over many years, and then we didn't have to invent it all again. We actually just copied them, right? And we said, look, we looked at their protocols and their materials, and we looked at what they were doing, and we copied them. And this is the really nice thing about human progress, isn't it? That you can just copy people, And we put all of our protocols on the web, and people copy them. And I see head injury trials with the outcome form that I designed that have nothing to do with me in different countries. And I think, oh, great, look at that. They've copied me. But that's the good thing, So, we can progress much more quickly by not, starting from the very beginning. But we can see this is part of our culture, you know. It's part of our culture. We don't need to learn. We don't need to start as if there was no culture there. We just, you know, this is part of our scientific culture. I mean, you know, we all use randomization if we can now. You know, that was invented by somebody. It was a good invention, brilliant invention. So we all copy it now, you know, and that's fantastic. That speeds up the pace of progress. What I think we're not doing is that we're not doing trials big enough. I think I would love to see a day where we get a question on a Monday and we get the answer on a Friday, because we've randomized, in that week, we've randomized 50,000 patients. You know, that's what I'd like to see. And I think it's a future that should be possible, you know, because now we're so much connected, the internet, you know, information's flowing everywhere really quickly. You know, it should be possible to do really big trials. You're doing a trial of mobile phone-based cognitive behavioral therapy for university students.
Yes.
You know, there's no reason why that should be bounded. You know, if you could translate things into different languages, you could go big quite quickly, couldn't you? So you could imagine how you could do quite big trials of that sort of intervention. Well, I can. I mean, can you? Do you think it would be possible to do much bigger trials of an intervention like that?
Oh, yes.
Yeah?
I think.
Yeah, because, you know, you can deliver a signal to, you know, lots of places in the world.
I did talk about how to, when you show us the moment of truth, that you tell us how to keep your team members. I just wonder, because the question 112 is also a live that still clinical trials. Before that, how did you gather your team members? What will you tell us some practical ways?
Well, I can tell you the truth, but I can't tell you. But basically, I told you that I really got burnt out. I was trying really hard to do everything myself. And actually, I'm glad you asked that question, because it's a lesson that I learned that I didn't tell you. What I thought is that I was essential. I thought that I was really essential to the success of the trial. And until I got really exhausted, and then I said, I hired someone called Halima, and I said, Halima, here's the protocol, you're in charge. And I went on my yoga holiday, right? And I thought, well, that's it. You know, I've given it over to Halima, it's all going to go down. It just kept on getting better and better. She was much better at doing it than I was. And I realized that actually, that's another mistake we make. We make a mistake of thinking we're good at all of the things. But we're not. I'm very good, I think. I'm very good at knowing what should be done. I'm much less good at doing it. So if I say this should be done and get the money, there's other people who know how to do it much better than me. At the back.
I'm curious how you were able to do something big so early in your career. I don't see that as being possible with needing to do having multiple papers every year for tenure. Maybe once you have tenure, it's more possible. How did you?
I mean, I was, I suppose the first crash trial, I was in my early 30s, and so I had done some research. I'd done, you know, I worked a lot on injury prevention. I'd done lots of small things. I mean, all of these small things, they're not completely worthless. I'm not saying they're worthless. One of the things, you know, writing papers, sometimes you've just got to learn how to write. to start with. So it's not wasteful activity, but what's the question? How did I manage to get the money?
Well, it's a nice idea to be able to lay one golden egg every 10 years.
Yeah.
But in academia, is that really possible early in your career?
Well,
Another 10 years before you do that.
well, increasingly, it is possible. Our university has changed. It used to kind of weigh people's CV. It used to put the CV on a scales and see how heavy it was. But actually, universities are moving away from that. In the UK, now, you have to say, every 5 years, the university is assessed by the government to see how good a university it is. And they only ask academics to give their 3 best papers in the last, 5 years. And so universities are realizing that its quality is more important than, well, in terms of numbers of papers, the quality is more important than the quantity. So if you can do less but better quality, that works. I don't know what it's like in Japan, but I know in the UK that's the way things are heading.
So the Ch.3, the treatment is tranexamic acid, right?
Mm.
The Ch.2 was a stroke.
Ch.2 is bleeding, extracranial hemorrhage.
Are we looking for Ch.4?
I'm thinking about Ch.4. This is the most difficult time. This is actually one time in between trials I find very anxious. In between laying big eggs is very difficult because you've got to get pregnant with the egg. So you've got to know what to do, and I find that the hardest thing. And
But now you have the collaboration, you have the confidence, you have everything. So it should be easier.
no, in fact, the hardest thing is the question. I think if you get a good question, then everybody will help you. But if it's not a good question, they won't help you. There are some questions that people can see are better than others. They thought, well, that's a question. I need to answer that. And you can tell when you've got them because, you think, oh, maybe that, and it doesn't. But when you get, I have to get a very big emotion for something. And then unless it grasps me emotionally, I can't do it. Because it's a bit like getting married because, well, you should be married for more than 10 years ideally, but it's a long-term relationship, so you've got to care about it for enough, for 5 or 6 or 7 or 8 years. That's what I find. Getting a good question is the hard thing. I don't think there are any more questions. Thank you.